Welcome back everybody to another chapter of our nephrology section here at boot camp. So now we're going to talk about a very important and a very high yield concept, which is electrolytes. Electrolytes are super important to really understand and internalize because it's something that's going to continue to show up for you both as a first year medical student on your board exams going forward and even as a resident physician. Electrolytes and management of these changes that can occur in the human body really affect our physiology, and thus it's very important to understand them. So if you all are ready, then off we go. So the first electrolyte we're going to talk about in this video is that of sodium. Super important sodium is to the body. The normal range of sodium is approximately 135 to 145 milliequivalents per liter. So if our sodium is greater than 145, we say we're hypernatremic, and if it's below 135, we say we're hyponatremic or below. It's very important to know that sodium is the major determinant of volume status in serum osmolality. Remember, we've talked about this previously as well, that water follows sodium. So if we have sodium retention in the body, that's going to cause water retention in the body, and the vice versa is also typically true, and that if we have excretion of high amounts of sodium, we are going to get excretion of high amounts of water. It's important for you guys to understand this concept and really appreciate this equation right here, which says that our serum osmolality is equal to 2 times our sodium plus our glucose over 18 plus our BUN divided by 2.8. I want you to appreciate here that the major contributor is this 2 times sodium. That is the value. If we change our sodium, that is going to significantly change our serum osmolality versus changing, say, our glucose or our BUN is not going to cause as much of an effect on this equation, as in it's not going to change our serum osmolality as much as changes in our sodium. It's also important to note that changes in levels of sodium is going to have a very important impact on our brain as well, because we know if we have a hyponatremic state, a low volume state, and we remember the principle of osmosis, what's going to happen to the water in the fluid if we have low sodium outside of the cell in a hyponatremic state? Well, the principle of osmosis tells us that water is going to flow inside of the cell. It's going to go from low solute to high solute, and this can cause problems in the brain because it can cause brain swelling to occur. And vice versa, what happens if we have high solute outside of the cell and lower solute inside of the cell? Well, now the water is going to go this way, and we're going to get shrinkage of these cells, which can also be problematic. So the key point here is to always think about the principle of osmosis when we're thinking about our changes in our sodium status, because that is going to affect where fluid flows throughout the cells. So first, let's talk about hypernatremia and some of the primary causes. I think a good way to break these up is to think about extrarenal causes versus intrarenal causes. That is, things that occur inside the kidney or within the kidney, or things that occur outside of the kidney to cause this presentation in a patient. The first one we're going to talk about is diabetes insipidus. And if you remember, diabetes insipidus is essentially a problem with ADH dysfunctioning, right? We either have central, where we don't produce ADH, or we can have nephrogenic diabetes insipidus, in which we do not respond to ADH appropriately. And remember, ADH stands for antidiuretic hormone. It works throughout the nephron to essentially retain free water. It's also important to note that when we talk about a hypernatremic state, the principal problem is that patients are losing free water. They have an increased concentration of sodium because they're not bringing back the free water to balance out the concentration of sodium within the body. So primarily this occurs in patients who have an inability to retain free water, or they have a lack of access to water, and thus it's causing them to have a very concentrated amount of sodium in the serum. So a patient who has diabetes insipidus is going to present with symptoms of polyuria and polydipsia, and something they might expect you all to do is determine, is this a central DI or a nephrogenic DI? And here's how we do this. So if you draw your attention over here to this little chart in the corner, we're going to talk specifically about the steps you can take to determine whether we have a central cause or a nephrogenic DI. And the first thing you're going to do, the best first test, is water deprivation. Why is that? The reason is that what happens if we stop giving somebody water? What would you expect to happen to their urine? You might expect it to get really concentrated. If we're not supplying water to the body, the urine is going to get more and more concentrated because we don't have that water to balance it out. That's what we would expect to happen. But what if that doesn't happen? If the urine continues to be dilute after we have deprived them of water, that indicates we have an inability to retain free water. And if we have an inability to retain free water through ADH, that meets the definition or the criteria to say, yes, this patient has diabetes insipidus. Because the alternative pathology or the alternative diagnosis, if they do concentrate their urine, that means they are able to do so, and that they might have a different condition, a psychiatric condition called psychogenic polydipsia. So if urine is concentrated after we deprive them of water, they might have psychogenic polydipsia, indicating that they're just drinking too much water, and that's why their urine continues to be so dilute. But once we remove that free water that they're drinking excessively, it actually can concentrate. That indicates that the body's physiology is actually working appropriately. Contrast this with dilute urine that remains. So now we've caused a water restriction. We expect urine to concentrate more as we're retaining what little water we have. However, it remains dilute. This is diabetes insipidus because they're unable to respond to ADH. We're unable to respond to our antidiuretic hormone that should retain our free water. And if we're unable to bring back our free water because we do not secrete ADH or we do not respond to ADH, then that free water is going to get ultimately excreted, and thus this is going to cause our urine to continue to be diluted because we're not reabsorbing free water. We're unable to do so. The next thing that we need to do is determine, is this central? Are we not producing ADH, or is this nephrogenic and that we're not able to respond to the ADH? And you do this through administering ADH or desmopressin. If this now causes our urine to become concentrated, that indicates we have a central cause. That indicates that once you give a patient ADH and the ADH goes and binds to the receptors, this is going to cause the release of aquaporin channels, right? Which will then bind on here and bring back our free water. If giving exogenous ADH allows this process to resume and we're able to bring back our free water into the body, then we would expect that our concentrated urine would be present because we've retained our free water. However, if this does not occur in that we give them this exogenous ADH and yet our urine remains dilute, that means that this receptor or the response to the ADH was not working. This channel is not going to open up. We're not going to secrete more aquaporins. So this whole system essentially does not work, and thus our water will continue to get excreted in the urine, causing this continued dilute urine. This indicates we have nephrogenic diabetes insipidus. So it's really important to understand these two tests. First is water deprivation, and the second is to give them an ADH analog like desmopressin. Between these two tests, we can determine, does this patient actually have diabetes insipidus, and if so, what type do they have? The next primary cause is hyperaldosteronism. So remember from our nephron transporter series and also in our pharmacology videos, we talked about the primary goal of aldosterone is to retain sodium in the body. And so if we have hyperaldosteronism, or an increased amount of aldosterone, that is going to increase our sodium retention, which can result in hypernatremia. Next, we're going to have a decrease in H2O or water intake. And we talked about how this can cause hypernatremia because typically we have a balance between our water molecules and our sodium molecules. But if we decrease our water intake, our H2O, we're going to naturally have an increased amount of sodium levels relative to our water levels. And this can again cause a hypernatremic state. And finally, things that cause increased water loss. So diuretics, diarrhea, vomiting, or burn are all different scenarios in which patients can lose excess free water without necessarily losing the sodium as well. So again, we disrupt this balance. I frequently talk about the word homeostasis because it's one of the primary principles of general biology and physiology. We have a balance of sodium and water. When we get out of balance and that we have too much sodium compared to water, anything that can cause that can cause a hypernatremic state. This list of causes is not exhaustive, as in it doesn't include everything, but it does include some of the most commonly tested things that I really want you all to know to get your questions right. So the presentation here should probably make a little bit of intuitive sense. So signs of dehydration. If we're low on free water and we're high in our sodium levels, signs of dehydration can be present. Additionally, we can get polyuria and polydipsia. So these are like things such as frequent urination or increased thirst, an increased desire to drink more water. And if severe, we can get seizures and coma. So anytime we have a very severe electrolyte derangement, we have much more severe presentations with these patients. So the workup for this condition includes what we talked about with the water deprivation test, as well as a plus or minus for desmopressin, which is an ADH analog. This is really high yield to understand. We went over it, but if you guys aren't really sure or not feeling super confident with it, go back and watch that little section again. The best test to do if somebody is hypernatremic is to water deprive them. This will tell you, do they have diabetes insipidus or do they have a psychogenic polydipsia? And then giving them that ADH analog will help you determine what type of DI might they have, if they have it at all. Really something that they like to test you all about. Again, central is a lack of ADH versus nephrogenic is resistance to ADH. So that's when the body is producing ADH or we give it to them exogenously, but their receptors are damaged and thus they don't actually respond to it. And finally, the management for high sodium levels includes fluid replacement. Remember, this is primarily a problem of volume level in terms of water status. When we don't have enough water, we don't have access to the water, or we're excreting the water, relative to our sodium, this is what causes our hypernatremic state. And then there are a couple unique treatment options for our different types of diabetes insipidus. So first, for our nephrogenic diabetes insipidus, which we said was an inability to respond to ADH, we can give them a thiazide diuretic and NSAIDs to treat nephrogenic DI. Why is that? And it's a little bit counterintuitive, right? It's a paradoxical effect that occurs. So by giving somebody a thiazide diuretic, we ultimately increase the amount of sodium and water reabsorption earlier on in the nephron. Why does this occur? So look at my little nephron that I've drawn for us over here. So we have the glomerulus, right, in red, and then my nephron in the yellow. So we typically think about thiazide diuretics as a way to offload sodium. And initially that is what occurs. We give them a thiazide, we cause more sodium to be excreted from the body and thus more fluid. So initially we make the problem a little bit worse, but then what happens is very important to the process. Once we lose more sodium in the urine, this then triggers the sympathetic nervous system. Remember, we talked about we have different mechanisms to respond to an increased loss of sodium and volume status, including the RAS system being a big one, as well as sympathetic nervous system modalities. This activation of the sympathetic nervous system and RAS system will cause an increase in proximal sodium and water reabsorption. So while we might be blocking some channels here in the distal convoluted tubule, because that's commonly where our thiazide diuretics act, it's actually going to increase our reabsorption in other parts of the nephron that are not the distal convoluted tubule. So paradoxically, or an unexpected effect, is that by giving a thiazide diuretic, we can actually improve their symptoms of nephrogenic diabetes insipidus by creating more of an anti-diuretic effect. Also, you should be asking yourself, why can't we just give them desmopressin, the ADH analog? And again, the reason is because they have an inability to respond to the molecule. The receptors are damaged versus there being an absence of the molecule. However, for central diabetes, you absolutely can do that because desmopressin or an ADH molecule is what the body is missing. In central DI, there's an inability of the body to produce the antidiuretic hormone, and thus you give them that as a supplement. And probably the least commonly tested one is the NSAIDs we talked about for nephrogenic diabetes insipidus, and that these work to decrease our prostaglandins, which are known ADH antagonists, and thus this would exacerbate the problem, so you give them NSAIDs to try and relieve this portion that might be contributing to the patient's pathology. And the final key point here is this pretty famous saying that you should have caution, and it goes, from high to low, your brains will blow. And that means if you're too rapid in changing a high sodium concentration state to a low sodium concentration state, you can create cerebral edema and herniation. Because again, this goes back to what we talked about at the beginning. If we have low solu inside the cell versus high solu outside the cell, and then we dump a bunch of water that is going to dilute the amount of solu outside of the cell, we now might end up with a scenario like this, in that the concentration of sodium is relatively low compared to what's inside the cell, and what's going to happen to the fluid then, given the principle of osmosis. It's going to rush inside of the cells. This can cause cerebral edema and ultimately herniation, which can be fatal. Again, you have to remember that everything is based on a concentration. So we didn't change the amount of sodium solute that is outside the cell versus inside the cell. We simply added more water, and thus the concentration of solutes decreased significantly. And so again, this is just something to be mindful of. When you're treating these patients, you have to do them at an appropriate rate so that we don't cause further or even a bigger complication. So next we're going to talk about hyponatremia, and the key here for this is that the primary causes are based on the plasma osmolality and clinical volume status. So this is a very dense understanding of electrolytes, and we're not going to talk about everything into super high detail because you don't need to know it at that level right now. This is very much a subject or a pathology that you will build your knowledge on over the years. So if we can really create a good foundation for you right now to give you a basic understanding of the different presentations, and then as you go through each year, you'll build and build and build, and by the time you start taking your clinical knowledge assessments, you'll be an absolute rock star. So one of the keys here is differentiating hypertonic hyponatremia, isotonic versus hypotonic. So these are all scenarios of hyponatremia or low sodium level overall. But if we have hypertonic or a high amount of solute and yet a low amount of sodium, this indicates that some of our solute must be coming from somewhere else. Remember the equation that we talked about up here, and that our serum osmolality is 2 times our sodium plus our glucose divided by 18 plus our BUN divided by 2.8. Yes, sodium is the biggest contributor to this equation, but it's not the only thing, right? Our BUN and our glucose also contribute. So if we do have this scenario where, yes, our sodium is low, and yet our serum osmolality is really high, this indicates there's something else in the serum. There's another source of osmoles, as we call them, that can be causing this. So hyperglycemia, high levels of sugar, or mannitol can also be causing this. These are things that might be picked up on our labs and picked up in part of our equation, but they're not actually sodium molecules that are contributing to it. And if we think about why this might make sense, let's say we have a cell with 5 dots in it, so 5 osmoles, let's just say for an example, and out here we have 3 sodium molecules, which I've dotted in black, but we have so much glucose or mannitol that we actually have more osmoles, I'm putting these ones in light blue, outside of the cell. Now what's going to happen to our fluid? Well, based on the principle of osmosis, we said that it's going to flow outside of the cell and cause shrinkage. So now we have a bunch of fluid outside of the cell in addition to a bunch of solute, of which is not necessarily sodium, and that's why we get this hypertonic hyponatremia, because we've diluted the sodium we do have due to the fact that we have other things causing this osmotic effect. Next, we'll talk about isotonic hyponatremia. So typically this is something we call pseudo-hyponatremia, in that it's laboratory artifact or an increase in lipids and proteins. So what do I mean by that? So if the serum osmolality level continues to be in approximately the normal range, roughly 285 milliosms per kilogram of water, that indicates that something is causing there appear to be a hyponatremic state, but the actual concentration of sodium is normal. This is often due to lipids and proteins, which can alter the plasma concentration, and some pathologies that might cause this to occur include things like multiple myeloma or hyperlipidemia. And finally, we have hypotonic hyponatremia, or what we call true hyponatremia. This is approximately less than 275 milliosms per kilogram of water. Keep in mind, depending on the source you look at, these numbers might change a little bit, but I'm just putting approximations here to give you all a rough idea of what range we might be looking at. So if someone has hypotonic hyponatremia, that means they have a low serum osmoles and they have low sodium. And thus we can deduce that the low sodium levels, or the low concentration of sodium, is what is causing the low serum osmoles, because again, looking at our equation, 2 times our sodium is our biggest contributor to what our serum osmolality is. So if this is the case, if we have a patient who has low sodium and low serum osmoles, now we have to break it up by their volume status. Again, this is very important for clinical medicine, but they do want you all to have a basic understanding of what kind of physiologic states or pathologies can cause a change in a volume status. So the first, we have hypervolemic, which includes things like CHF or congestive heart failure, cirrhosis, low urine output, and low protein, such as our nephrotic syndrome. I'm clumping these all together because I want to think about what's the end product of all of these. It's higher levels of water. It's higher volume in the body. With CHF, we know that we have a worsening heart function, and what's that going to do to our fluid levels in our kidneys? It's going to decrease them. If we decrease the fluid that gets to our kidneys, that's going to activate our sympathetic nervous system and our RAS system to bring back more sodium and more water. And so these patients tend to have a high volume state, right? Because they're not getting blood out of their heart, and thus their body thinks they're low volume, and it will continue to work to bring back more and more fluid and more volume. This is why commonly when we have patients with congestive heart failure in the hospital, we are working to offload some of that fluid with the use of diuretics and various other modalities. Cirrhosis is somewhat similar in that we get some congestion within the body. We can get some vasodilation occurring systemically because of the products that are released, and this is also going to cause us to retain more fluid because our kidneys sense we're low on that fluid, and thus it works to bring back more. And now we have a two-edged sword, and now we're retaining fluid from a variety of different pathologic processes. If we have decreased urine output, that should make sense why our volume status should be elevated, because we're not offloading the fluid as we normally would. And finally, if we have low protein levels, such as in nephrotic syndrome, where we are low in our albumin, what's going to happen to the fluid in the vascular system? Where's it going to go? So let's say we have 5 solutes in the vascular system and 5 solutes outside the vascular system or in the extravascular space, and then a patient has a nephrotic syndrome where we know the solute levels in the albumin and the proteins in the vascular system are going to decrease. So now we only have 3 solutes in the vascular system, but there's still 5 outside. Where's the water going to go? It's going to leave, right? Principle of osmosis occurring once again. This is going to cause fluid retention in the body, and thus a hypervolemic state. Next, we're going to talk about a euvolemic hypotonic hyponatremia, the first of which is SIADH. So remember, this stands for Syndrome of Inappropriate Antidiuretic Hormone. That means the body is secreting too much ADH. We are retaining too much free water. So what happens here, and why does this cause a euvolemic state? So if we have SIADH, we are going to have too much release of ADH and thus a high volume status. And so this is going to decrease our serum osmolality. Why? Because we're bringing back free water, and thus it's going to dilute what we have in our serum. This is then going to cause a slight increase in our volume status, and our body is going to respond to this once it realizes that we're increasing volume, and it's going to have those stretch receptors in the heart release its ANP and its BNP, which is going to ultimately decrease our aldosterone levels in the body, and this is going to cause us to excrete some of that sodium and excrete some of that free fluid. So in SIADH, we will have an increased release of antidiuretic hormone. This is going to cause a decrease in our serum osmoles in our body because we're continuously bringing back free water without an associated solute. So this is going to dilute what our body has, and thus it decreases our osmoles. This is going to be sensed as an increased volume status in various areas, including in the heart, where our body will act to counteract this, again, trying to maintain homeostasis by releasing more ANP and BNP. This is going to decrease our aldosterone levels, which is going to cause us to excrete more sodium and excrete more free fluid. And this is why we don't end up having a hypervolemic state in SIADH. We only end up having a euvolemic state because our body essentially acts to counteract the ADH that is being released. And so again, we'll get a euvolemic hypotonic hyponatremia. And finally, the last one we'll talk about is decreased sodium chloride intake. So this is often referred to as the tea and toast diet. A lot of times the questions will present to you with an elderly patient who might be living on their own, and they basically just eat white bread, toast, and tea all day or coffee, and they're not getting any substantial nutrients that they need to kind of regulate their body and have the correct amount of electrolytes needed. And a key point for this is that patients who are not ingesting enough sodium chloride would have low urine osmoles in addition to a low serum osmolality within the serum. So this is one way to check. If they're just excreting a bunch of sodium, you would expect them to have a high urine osmolality or a high concentration of sodium. But if they're not ingesting enough at all because they're on a special kind of diet, tea and toast is a common one. This can also be seen in people who drink excessive amounts of beer and only get their calories from alcohol versus other types of foods. They are deficient in sodium chloride in general. And finally, hypovolemic hypotonic hyponatremia includes low volume status, diuretics, or Addison's disease. I think the low volume status should make sense to you, as well as the diuretics, right? If we're decreasing their sodium levels through diuretics and we're offloading their fluid, that's going to cause a hypovolemic state. And Addison's, the primary reason is that it's a primary adrenal insufficiency and that the body has an inability to secrete aldosterone. And we know aldosterone is a primary driver of our volume status in terms of our sodium reabsorption. So if we don't have access to secreting that molecule, we're going to decrease the sodium in our body and thus decrease the fluid in our body, creating a hypovolemic, hypotonic, hyponatremic state. The presentation here can be a little bit non-specific, but you can get headaches, nausea, vomiting, and then of course, in severe cases, you can get a seizure or a coma. And finally, to wrap up this big video, we have our management techniques. So it's all based on clinical volume assessment. So somebody who has hypervolemic hyponatremia is going to get fluid restrictions and a loop diuretic, right? They're hypervolemic, they have too high a volume, we need to offload some of that fluid. Because if we offload some of that fluid, that may allow our concentration levels or our sodium balance to regain its normal status. If somebody has euvolemic hyponatremia, we can fluid restrict them as well, and we can do plus or minus hypertonic saline or salt tablets, as well as an ADH antagonist if they have SIADH. So fluid restriction, again, because changes in sodium is primarily based on changes in water. So we restrict that fluid, but because these patients have a low sodium level, we can give them a salt tablet to increase their sodium levels, or we can give them hypertonic saline as a fluid to essentially increase their sodium levels relative to their amount of free water. This is typically only reserved for very severe cases, so a patient who had a seizure or coma, but nonetheless, it is a management strategy. And then for someone who has SIADH, we talked about why that causes euvolemic hyponatremia, you can give them an ADH antagonist. And this should make sense. You're essentially blocking the molecule that we have too much of. Be mindful that for patients with SIADH, we would not want to give them normal saline. Why? Because this would worsen the problem. You might think, yes, we're giving them some salt, but the problem is that these patients have an excess amount of ADH, which causes them to retain more free water relative to the amount of sodium. And because our urine sodium concentration is typically greater than that of what a normal sodium chloride fluid mixture might have, patients are likely to excrete the sodium at a faster rate than we are actually able to give it to them through the sodium chloride. And so this is actually going to worsen their hyponatremic state. This is a little bit more of a clinical thing for down the road, but just something to keep in mind. And the final one to talk about is hypovolemic hyponatremia, in which you would give them isotonic saline. So this is able to replenish their fluid levels and their sodium levels. And finally, another caution here that's very important to keep in mind. from low to high, your pawns will die. So the whole thing essentially goes from the top. From high to low, your brains will blow, and from low to high, your pawns will die. And that is the opposite reason of what we talked about previously. It has to do with osmosis, right? If we rapidly correct hyponatremic states too quickly, this can cause a shift in fluid in the cells in something that's called osmotic demyelination syndrome. This is very, very bad. So we need to be mindful that when we're managing these electrolyte abnormalities, we need to not only give them the correct option for management, but we also have to be mindful of how we do it and making sure that we're not overly changing the body's current physiology, because again, this can cause other and sometimes more severe problems for the patient.